Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This is Aebhric. This week, we're with Krissie Stiles, who is a burn specialist who is currently working in the UK and has been popping up on social media with evidence-based medicine and how to correctly deal with burns. Krissie, welcome to the program.
Thank you so much. It's lovely to be here.
Tell us a bit about yourself and what's keeping you busy.
So I've been a nurse for the last 20 years and kind of fell into burn speciality straight out of training, which is very lucky to discover your passion so early on, but it happened to me. So your dreams do come true, to be honest. I was a ward nurse initially on the burns unit, then advanced into critical care, where I spent most of my time, and then evolved into the burn care educator to pre-hospital care providers and non-specialist providers whose role it is to look after burn survivors as part of their clinical roles. And it kind of stuck because what I realized is that whilst it might be very easy for us in the burn services, relatively easy, to have a very large team who looks after the patient, for my colleagues in out-of-hospital care, it's not quite so easy, and the resources are limited, and the colleagues you have around you are less. So I wanted to kind of dedicate my teachings and my interactions with that community to learn from them on how tricky it really is to care for our patients in those first few moments, hours, and sometimes days of that remote extended field care. And that's kind of where I'm at. A lot of my posts that you reference are to do with that early management, early care, the challenges of that. And hopefully by learning from each other, we're troubleshooting together and learning as we go. And that's where my passion lies.
That's pretty amazing that right off the bat, you sorted out precisely the specialty you wanted to do. How did that come about? How were you drawn to burns as a specialty?
It's incredible, isn't it? I was a second-year student as a nurse, and we had a burn specialist nurse who came from our regional burns unit to the university to do a lecture on burns. And he spent about 2 hours showing us really severely injured patients and all the latest technologies and elements of surgery, recovery, nursing of these patients. And a lot of my colleagues around me were unable to look at the screen. A lot of them were turning away going, this is really terrible, can't deal with this. And for me, it was quite the opposite effect. I was like, I want to be part of this. Like literally the whole person's skin is gone, it's severely damaged, and somehow they recover and then are made to, go back to life and sometimes even improve their outcome and, go back to some quality of life. And I just wanted to be part of that. It seemed so fascinating. I asked at the end of the lecture, literally ran up to the lecturer and said, how do I get on the burns unit? So he said, you have to request an elective placement. I went for my elective placement as my kind of last placement of year 3 nurse training, and I stayed. I was offered a job whilst I was there, and I just loved it from the off. I wanted to know everything and anything there was to know about how the burn injury happens, how the body responds to a burn injury, all the technologies, all the techniques that we have for caring for burn survivors. And then, of course, realizing that just because their wounds have healed, that's not the end of their journey, that they stay our patients or in touch with us as clinicians for the rest of their life sometimes. And that was just fascinating. There isn't any other disease process that potentially leads the patient to be that close to their clinician for their whole lifetime. I wanted to be part of it. So it's never left me. 20 years in, trying to shake it off, but it's not leaving me, and I love it.
I am impressed. I've been in burns wards, and they're always very warm. As an Irishman, anything that warm is a challenge. And then, the smell and the challenge of the burns dressing changes, and sometimes you have to put them into a ketamine shower or put them into almost intubated state. It's not pretty. So what was it? Why? So you just mentioned about the fascination of of treating this disease for longitudinal experience with the student, but what was it that kept you challenged to stick with a burns casualty?
I think initially when I started, I was just lapping everything up. So I was learning very new information. If I hadn't had that lecture at university, I would never have even realized that there was a burn care speciality, because I was being rotated through your usual standard kind of medical surgical nursing wards, ED, ICU, but I never really thought beyond that there might be other really interesting specialities out there. So once I discovered it, I spent the first couple of years just learning. But then it got to the stage where you're rotating around the burns unit. And the way that a lot of burns units are set up is that you don't just nurse patients on the burns ward. We are like our own small contained hospital. We're very separate to the rest of the hospital environment through the fact that it has to be highly attuned to infection control, and our patients are immunosuppressed patients as a result of their injuries. So we are very separate. And as a nurse, I could look after patients on the burns ward. I could choose to go and help out or work in the ICU environment, or in an outpatient's clinic, or scrub in theatre. So you literally see the full patient's journey. So that was very different to your nursing on the surgical or a medical ward, because you explore all those things that you would normally need to move to a completely different ward for. And then as I became a more senior nurse, you started taking charge of actually receiving referrals from A&E departments, from doctors and nurses who were treating these patients first. And they would seek advice. We've done this, this and that. What else do we need to do? Can this patient now come to you? Do you have a bed? So you became a coordinator of that patient's journey to your unit, and supporting, remotely supporting non-specialist care providers, giving advice whilst you are kind of helplessly waiting for the patient to arrive. You still had an opportunity to intervene to make sure they still had best practice approach in those out of speciality areas. And once the patient arrived to us, I would coordinate the admission to our operating theatre, because as soon as the ambulance personnel brought them through, you'd weigh the patient on the weighbridge and straight away take them to the burns operating theatre, look after them there, do all the initial assessments, initial tests and interventions, and then bring them through to ICU or the ward areas. And I could get involved in all of that. And then on top of that, everybody is interested in your speciality. So then you get an opportunity to be the educator, to run specialist training courses. And so you get colleagues who come in from primary care, secondary care, from pre-hospital care environments, who are interested to hear what you have to say. How do we look after these patients? So, whilst I'm a nurse on the burns unit, I was also the educator, the coordinator, the sister in charge, all of these other opportunities to be the support system for the patient and their family. It's incredible hit of adrenaline, and it is an endorphin rush. Like you said, it's not an enjoyment, but it kind of is, because I was loving that way of helping a person through this incredibly traumatic and quite often unexpected injury. And sometimes patients would return to the outpatients clinic to have their dressings changed, or further down, once they're already recovered and no longer have dressings, they'd come to the unit, bring flowers, bring whatever to say thank you. And they'll go, Krissie, oh my God, you looked after me. I remember you. And I would look at them and think, but I don't remember you, because you look like a normal human being. You're dressed in clothes. You don't have dressings. You look well. Who are you? But of course, it's incredible the impact that you as a clinician can have on that patient's recovery, on their attitude in life, how you've supported and bullied them through most painful, incredible, the dressing changes you mentioned, the therapy that they have to start from day one, and all of that, and then psychological burden of actually acceptance and dealing with the fact that you look different, your body behaves different, you'll never be the same in a sense. Maybe you can't go back to your work in the same way. All of these things as a bedside nurse, and certainly a bedside nurse in ICU, you are part of that process. You're part of supporting the patient and the family. And when the patient's sedated, you're supporting the family members. So in fact, you get to know the patient through the family first whilst they're sedated, and then they wake up and you get to know them and carrying them and support them through the hardest steps that they have to take. So I could talk to you all day about it, but it is the best speciality. It is the most insightful way to support somebody who's terribly ill from massive thermal trauma, and then to see that patient walk out of the burns unit and go and get on with life is the most satisfying feeling a clinician can ever have.
It sounds like this specialty is probably one of the ones where you can spend the most time with casualties. It's longitudinally. You're dealing with this casualty longer than most other specialities.
Absolutely. And certainly in case of pediatric patients, they come into us. Mostly there are under fives who suffer burns, and from that age onwards into adulthood, they are our patients. And then quite often they will become peer supporters through burn support charities, become ambassadors for these charities, and they return back into the burns unit or into the burn survivor environments where they continue supporting not just us as clinicians looking after new patients coming in, but also the families of burn survivors further down the line. So you're always involved in that patient's care, from pre-hospital to acute, to in rehabilitation, to recovery, to the rest of life. And that is an incredible thing to be able to have as a clinician, I feel.
I see your passion. I see why you enjoy this specialty that so many other of us, when we come into the burn ward, we are challenged to be there. But yes, you're seeing the humanity behind the burn. That's very commendable.
Yeah, I mean, obviously, as a newly qualified burns nurse, you are confronted with the fact that it is a very visible injury. It is quite shocking. It is horrifying, but you also are very aware that it's happened to someone else, and for that person, it's way worse. You know, you are there not to be the mirror to them. You are there to be the support mechanism, the crutch that they rely on, somebody who tells them, yes, it's going to be rather rubbish for a very long time, but things will get better. I promise you, things do improve and you do get on with life. And they need that. Initially, they don't want to hear it. But of course, you know, through guidance, through immense support that the burns teams can offer. And we have counsellors and clinical psychologists as part of our team. They are an integral part of the team, supporting the family and the patient and us as clinicians at the bedside, because it is an immense trauma to look after as well. You can't help but take these thoughts of these patients home with you and, you know, think, could you have done anything different? They do stay with you for a long time. And I'm sure every clinician who's ever looked after a burn survivor in whatever environment, there will be one that they remember. More than one, no doubt, but they stick with you. And you want to be able to not just be horrified at the nature of the injury, because it is horrendous, but also be absolutely amazed at the strength of human spirit and the ability of the human body to recover from something that dramatic. So there is the smell, there is the heat of the burns unit, there are the painful dressing changes, and no doubt they stick in our patients' minds for a very long time too. And certainly the relatives that have to visit the burns unit regularly and stay at the bedside whilst the patient is recovering, and different mood swings that they go through and different stages of that grief and loss and recovery. But that's our job as clinicians, to be the neutral party, to be the balance in that, to not allow them to grieve too much, but also not to get too positive, because they have stages where everything comes crashing down. It's like a wave. The recovery is never linear. It is a little bit like a wave, and we have to be there.
What type of burn casualty do you particularly find challenging?
That's quite a tricky patient. Majority of patients that we see in critical care are on the burns units will be the flame injured patients. So they tend to be the biggest, the deepest, with complications like smoke inhalation injury. So they tend to be the sickest patients that we'll look after. So in terms of, who's the trickiest, that probably is, the bigger the burn, the sicker the patient. So they will be your long-term complicated patients who'll go through the initial throes of the massive inflammatory response and then potentially go into the sepsis picture, go through multiple surgeries throughout their stay, and thereafter, to come back for reconstructive surgery for their scarring and contractures. So it's never that linear, like I said, it's never that simple, but the big, deep burns with smoke inhalation, they are challenging. For me personally, I found patients who were very similar background to me. So females who were my age, who came from possibly very similar circumstance and background, who are now in the bed in front of me and I'm caring for them. It was really tricky for me to not relate that and make myself feel vulnerable. And it's selfish to say it, but ultimately we are not just clinicians, we're also human. And I did feel that kind of my own mortality. I felt it more because I had the person who could have been me laying in that bed opposite. And that was really tricky. And that's where I say we have clinical psychologists, we have counsellors as part of the burns unit, and they're there for your clinical supervision, for the debrief whenever you need, because you never know when you might get triggered by the person that you're looking after. And the team are fantastic. You could very easily flag up to say, actually, you know what, I'm triggered by this patient or their injury or their circumstance. Do you mind if I look after someone else? So you could swap with your colleagues and, not put yourself into that place, which could actually be quite damaging for you as a person, for your mental health.
It seems to me like this specialty will self-select only the best practitioners, like the docs, the nurses, the ward staff. You have to be a particularly strong individual to work in this environment.
I mean, obviously, I would agree and say, yes, we're all made of very strong staff. And you do see that actually on the burns units, people who come to work on burns, who love it, who get it, they stay for decades. You have people who just don't want to leave their speciality. It is their centre. It is where they practice and they conduct their business. But you equally have some clinicians who will come and very quickly decide, you know what, no, not for me. The difficulty with the setup of the burns unit in the same sense that the things that make it great are also the things that are not so great, because as a junior nurse, it's very difficult to progress through the ranks because the seniors are not leaving. People stay for a very long time. So actually we saw the rotation of more junior staff for that very reason, that there wasn't progression that they were craving. They wanted to advance. They wanted to be more senior. But it's harder within a very small niche speciality. So you'd lose potentially really good people because there just wasn't the placement. There wasn't the positions for them. But yes, we are. You love it and you stay there because you love it. You couldn't do the job otherwise.
Indeed. Where have you practiced as a burns nurse?
So my centre was Queen Victoria Hospital in East Grinstead. It originally was the centre where the RAF pilots called the guinea pigs were looked after by the surgeon called Mackindoe, Archibald Mackindoe. And that was in the Second World War, where he pioneered reconstructive surgery for burn survivors. In a sense, he also pioneered the recovery and social reintegration of the burn survivors back to community. He impressed that the burn survivors on the burns ward had to get dressed into their own clothes and not be in hospital issue pajamas. They had to go out and go into the towns and mix with the locals, go to the pub and have a drink. And he also really campaigned with the local population to say, these are your heroes who fought for you. And you need to make sure that they're welcome, that you celebrate them, that you don't shun them just because they look disfigured and look different. You need to really embrace them back. And this is exactly what the town of East Grinstead did. And since then, Queen Victoria Hospital became the hub for burn care, with many burn survivors still being cared for. So 15 years of my practice was as a nurse on the burns unit at Queen Victoria Hospital.
So for the paramedic, for the nurse, for the remote medic, what is a way that they could get experience with the burn casualties? Is there a way to volunteer for the burns ward, or how can people who are interested in this get some experience?
So first of all, you want to find out if you really do want to get that experience, and turning up on the burns unit and then realizing within half an hour that, nope, this is not for me, is going to be quite awkward. So potentially I would say reach out for the educational opportunities that are available through burn networks regionally, and also specific burn centres that run their own educational study days. Go to those, see the images, hear the clinicians speaking, learn about it a little bit more before you decide that I definitely want to actually have a hand-on-hand experience with these patients on the burns unit. And then if you decide that actually, you know what, I do want to progress, I want to get a bit more into this, then you could get an honorary contract with the trust. So approach the burns units directly, say, I'm interested, could I have a placement? Could I come and be seconded maybe, or just come for a day? There is obviously the political element of organising the honorary contract, making sure that HR and DBS checks are in place to make sure you're safe to be on the unit. But after that happens, we have practice educators on the units who would look after you, who would help you experience the burn service as it is, and every element of it as well. So that's really great. I would also really encourage our outer speciality care providers, nurses, doctors, paramedics, to come to our annual conferences. We're really lacking those voices. I desperately want to hear from all of you guys, your challenges with looking after our patients in the first moments, hours of their injury. And those voices are not present during our annual meetings. And I would love to encourage all of you to present. Come tell us about your challenges. Come tell us about what it's really like to look after burn survivors in your environment. Because we need to be talking, we need to be interacting, and not to keep this knowledge to ourselves. Through sharing, through integration, through experiencing each other's challenges, I think our patients would be better off for it.
So it's a good advice for anyone interested to go to some of the conferences. But is there a way to do that back to front? So is there a way to have you come to some of our conferences, the Combat Med Conference, the DIMI Med Conference, the Disaster and Military Medicine, the SOMA Conference? Have you done any presentations for some of our conferences on burns and austere environments?
So as you know, as we discussed before we started recording, I've done a few podcasts recently, and certainly I've done a number of posts on managing burn survivors in austere combat and tactical field scenarios. I don't have personal experience with it, so I know what I read and the latest guidance that comes out, and that's where I tend to source my information. But I also come with experience of having looked after patients on the burns unit and seeing their outcomes years and decades down the line. So I know what matters to people that far down. So it is really important to have that connection, and I would be more than happy to present at all of those conferences that you mentioned. Just, invite me. I would love to come and learn with you, discuss these cases with you. I've spoken at paramedic conferences many times, so majority of my work is probably with the fire service and paramedics, and certainly that first response, the more formal kind of within the NHS, within the Western community response, I definitely have integrated in that community, have presented to them, but not so much to the austere and remote population. So maybe we can make that happen.
Perhaps we'll have to see what we can create. So speaking of resource limited, what is the best way to treat a burn if you haven't very much equipment at all?
Yeah, I can appreciate that you kind of only have what you can carry in your pack, and that's all you've got. And quite often it needs to be kit that can apply to other manner of trauma, not just burn specifically. Otherwise that would just dominate, and it's doesn't happen that often. So actually burn injuries are relatively rare when you compare it to other forms of trauma. So obviously it depends on the mechanism of injury. There are multiple mechanisms, the way that the burn injury happens. And potentially each one of those will require very specific treatment pathway. But very simply, they're broken down into the thermal component of injury, things like flame, scald, contact burn, radiation. And then also you will have things like your friction, your electrical burns, your chemical burns, frostbite as well. So your remote medics, your austere environment clinicians might see more frequently than others. Like I said, with flame burns, they tend to be the biggest, the deepest, with the problem of inhalation injury. Scald injuries are probably the most common. Contact with hot surfaces can happen, but usually are on the back of somebody having other comorbidities, like having an epileptic fit and then falling against a hot surface, or falling into a fire, for example, or having a heart attack and then collapsing against a hot surface. So there's normally something else that's aligned with the burn injury per se. Electrical injuries, if it's a high voltage, that can be really problematic, and patient could actually have lost consciousness and be in cardiac arrest scenario, and that's then an issue. That's a priority in care, never mind the burn. But in the long term, there will be potentially muscle damage and deep tissue damage that could complicate the patient's outcome, could lead to fatality. And obviously with chemicals, what chemical has been spilt? How do you decontaminate it? Is there an antidote required? And with frostbite, the management is kind of the opposite of everything else. It's, rather than cooling the burn, you're rewarming the frostbite injury or the cold burn. So each one of those has a very particular pathway. But the key things that will make a massive difference to all of those patients is that if you have a major burn patient, you treat them like a trauma patient with a burn. So you identify the key elements of their presentation that are likely to kill them first. You follow your ATLS approach, you do your primary, secondary surveys, and eventually you discover that they're burnt, and then you deal with the burn. But there has to be that process of approaching them trauma patient first, burn second. The burn injury is very unlikely to kill the patient first. Whereas if it's in a more minor burn, which are more frequent, then cooling of the burns is the essential key intervention. And that in the remote setting can be problematic, because the best practice advice is 20 minutes, cool running water within 3 hours of burn injury. Now for that, you require access to water. You require volume of water to last you 20 minutes. And obviously you have to somehow, ideally, regulate the temperature of that coolant that you're applying to the surface of the patient's wound. And all of those might not be available, or might be available in bits and drabs, but not as a total whole of 20 minutes pouring water. So you have to consider what happens if I do this. So if I have all the resources and I do it, what's the outcome for my patient? And what are the consequences if I don't do this? Because I simply just don't have access, or I don't have the resource. And I hate myself for saying it, but no patient has died just because you've not done burns first aid. And it absolutely kills me to say it. But ultimately, nothing bad will happen. It's not like they're bleeding and you haven't stopped the bleed and they're dead because they're bled out. With a burn, it's different. It's the heat that is retained within the tissues that continues damaging your cells. That basically means unless you cool, you're getting a deeper and bigger burn injury as a result of you not cooling. That's the bad bit that happens. The badness actually comes later. It's that quality of life. And you have to consider that me not doing this cooling right now, on making sure that they get it within that 3-hour window, because past 3 hours, there's no point doing first aid. It's not effective for the tissues. So if I don't do it within 3 hours, my patient is more likely to require surgery. There's going to be more area of their skin that requires a skin graft operation. They're more likely to suffer infective complications. They're more likely to heal to a scar and stay in a hospital for a very long time. So scarring is the ultimate complication, and scarring in itself has a life of its own with contractures and functional implications if it covers any joint surface. So when you're talking about what are the key management strategies, what are the trickiest parts of looking after somebody with a burn injury in a remote setting, it's the fact that the burn injury will behave the way that it behaves, and everything is off. You're basically by doing your interventions, you're preventing potential future outcome for that patient. So in a major burn, you'd want to look after their airway, their breathing, secure the airway. Therefore, they can swell around that airway. But if you've got a definitive airway, clearly that's okay. Breathing, circulation, you want to make sure that you replace the fluid losses on the back of the massive burn shock that happens as a result of the burn injury. You want to make sure that you look after their wounds and that they're covered and they're as clean as possible, and eventually they get to a burn specialist. All of these elements are offsetting the potential poor outcome, the worst one being death, for that patient. In a more minor burn, the outcome is still scarring. That's the worst thing that can happen to that person. And if it's on your hand, or if it's on your foot, or if it's on your face or your genitals, or to be honest, anywhere on your body, it's bad enough if you have a scar, because it becomes a visible difference to the community and the people around you. They will look at you, they will stare at you, they will judge you. People might treat you different because you have this visible scar, visible difference on your skin. And also your body will behave different for having the scar. The scar itself doesn't stretch. It's not very pliable. It also doesn't sweat. It doesn't have hair follicles, so it doesn't moisturize itself. There's no oil glands present. So you suffer the consequences of having skin that is healed, but now behaves very different to how skin should behave. And if it's a reasonable surface area that has a scar, then actually you don't sweat in that patch, but you profusely sweat out of all of the other uninjured areas. So thermoregulation is a massive problem in the long term for these patients. And it's really difficult to talk about that long-term outcome when you're saying, well, it's just happened. I'm the first medic. I'm on first response team present. Why am I thinking about that patient's scar not sweating? But this is what I actually want us to think about, because if it was you or me, that's the bit that's going to matter. You won't remember what dressing was put on as the first dressing, or whether or not the cooling was done or not, or even if you were in a lot of pain or not. Further down the line, the bit that affects your quality of life is having to live with the consequences, not just of the injury itself, but of the consequences of the decisions that were made at scene, those first interventions. The decision to intervene or not to will have a consequence for that patient.
So the benefit of aggressive cooling is to increase their quality of life, not necessarily make a lesser burn.
No, inadvertently it will reduce the depth and size of the burn by you doing the cooling. But in the long term, the reason why we want to reduce the depth is so that if it's not that deep, it doesn't need surgery. Therefore, it heals within a number of weeks and it's less likely to scar. So yes, it's avoidance of that potential outcome for the patient.
So in austere environments, we're suggesting if you don't have a huge amount of water to do mist and fan, and unfortunately there's not a lot of research on PubMed on using a mist and fan approach. Has this come across your desk, or do you have any insights on rapid cooling with limited water?
So the options that are given by the burn specialist, and just I think as a caveat, most things in burn care don't have much in way of evidence or background research for it. We've done it for many years. It kind of works, but there is no evidence for a lot of the interventions that we suggest. So ultimately, we do the things that we know will work for our patients. And certainly with water cooling, there is now a growing body of evidence to say, yes, this stuff really works. I know it's not like a clever drug or a clever dressing, but out of the most simple things comes out the best possible outcome for that patient. And that body of evidence for running cool water, 20 minutes of it within 3-hour window is really mounting. So that we definitely know that stuff works. If I don't have water, running water, the next best thing is a cold soak. So cloth that if you have limited amount of water that you can wet and apply onto the very hot burn wound. Bearing in mind that the heat of the skin will penetrate into that cloth and will warm it up very, very quickly. So the advice is you still do 20 minutes of total cooling with these soaks, but replace the soak with a new one. So you're kind of refreshing the cold soak every 3 to 5 minutes for a total amount of 20 minutes. That's effective. Now, I have, similar to what you mentioned, the mist and fan. So you're spraying water and then you're fanning with whatever you hand, paper, whatever, just to allow that evaporative cooling to start happening. It works really well in heat-stressed casualties. I assume it will equally work very well to cool the surface area of that burn by doing the mist and fan. There isn't evidence out there to say that stuff works, but it is practiced by many paramedics. And certainly if you're traveling in the back of the ambulance and you need to continue cooling, a lot of paramedics now started carrying spray bottles and literally just misting over the bed sheet. They'll put a bed sheet over or clean sheet over the patient's wounds and continue spraying as they go. So they're constantly refreshing. So rather than doing mist fan, they just kind of spraying cool water over the surface as they travel. It prevents the whole cab being absolutely drowned and drenched in water, but equally you're containing the liquid only on the wounds that need it, because the saying is you cool the burn, but you keep the rest of the patient warm. So cool the burn, warm the patient. That's also very important. What we're talking about in the low resource setting is doing the best you can. You're trying to make the best out of a bad job almost. That you have what you have. You might have, for example, dirty water. You might have lots of it because you're next to a lake or a dam or a river, but you can't guarantee the quality of it. So the question then is, well, do I use the dirty water? Because I know cooling is important, but then I equally understand that contamination is not going to be great for this casualty. So these are all the discussions that we need to have amongst ourselves to say, we know that stuff works, but is it in the best interest of the patient? I'll cool, but I'll give them an infection and sepsis from which they could potentially die. Or is cooling that much more beneficial that actually they will recover and the burns unit can treat the infection? That also could be an option, but it depends how far away from that definitive care you are. So you don't want to complicate your management, that extended field management of the casualty, by making your patients sicker. When it comes to cooling, you need to consider the options of, I don't have water or I have limited water, will spray and fan work? I would say yes, still do what you can. When it comes to dirty sources of water, if you have really contaminated water, you have to consider, is that still going to be beneficial? If you're reasonably close to getting access to definitive care for that casualty, I would say you can use the dirty water, but once they get to definitive care, they will douse them with clean water just to wash off, and that can be effective. And if you tell them the first aid was done with unclean water source, we can start treating for infective complications as soon as they're admitted. The other big issue for our patients is hypothermia. It is absolutely massive. And you will be very aware of the fact that in trauma, hypothermia kills our patients. Well, these are your trauma patients. The trauma triad is absolutely alive and present in burn survivors, especially big burns over 20% surface area. So hypothermia is independently responsible for mortality in our patients. So when we're talking about cooling the burn, you don't want to overcool the burn. And if it's a big surface area burn, are you actually going to kill them by doing the cooling? So the consideration of the temperature of the water that you're applying, the coolant that they're using, it can't be cold. It can't be ice. So you'd make them much, much sicker. Anything ice cold and really, really cold will not only cause the core temperature to drop, but equally will cause vasoconstriction at the surface area of the skin, which actually means that your blood vessels are shut down. There's no oxygen or nutrients getting to the skin that's already struggling, and you actually are making the burn injury progress to being deeper and bigger by the fact that you're applying something really, really cold to their skin. But in your head, you're doing cooling. So don't do cold stuff to burns. Then the question is, well, okay, you can't cool them with really cold stuff, but what is the temperature? And can you actually regulate for that in the low resource setting? Ideal temperature is 15 degrees and above, and anything between 15 degrees to 37 actually is effective cooling for a burn. I mean, you're never going to get 37 degrees unless you're somewhere really, really lovely and tropical. But ultimately, as soon as it hits the skin, it's no longer 37 degrees. And whatever heat is in the tissues is going to be way hotter than 37. That's why it's causing the damage, is because it is that hot, usually around 70 degrees warm. So you want to, so 37 degrees warm to 15, that's your range. So if you're in a controlled environment, ideally you cool with as warm as the patient will tolerate. That's the temperature of your coolant. As soon as they go, oh my God, that's really lovely, thanks for doing this, that's the temperature. You don't want to overcool them. You don't want to make them cold. You don't want to give yourself an added complication to then have to manage. And if they start showing signs of hypothermia, and you're really concerned that actually this cooling is not doing them any good, and you've done maybe 10 minutes, stop. It's enough. If you have capacity to get the casualty to definitive care within that 3-hour window, just make sure that you pass on the responsibility for cooling to that place that potentially can do it in a more controlled, cleaner environment. Because that's the bit that you don't want to lose sight of, is the fact that the clock is ticking, and 3 hours later, there's no point doing first aid because it won't do anything at the tissue level. It won't reverse the damage of the burn.
I always cringe when I hear someone mention use of ice, and I just could imagine it makes the burn worse.
Yes.
Because it constricts the tissue to trap the heat in. And I can't believe people are still teaching that.
Yes, no cold stuff on a burn. I know it seems to go against the grain. They've been very hot. I need to cool them, but you actually are cooling them with, we describe it as tepid or lukewarm, but even that often I find is on the cold side rather than on the warmer side of the temperature scale when we actually apply it. So you want to use your patient as your thermometer. They will soon tell you if it's too hot. So ideally aim for as warm as they will tolerate, and then that's the bit that will be most effective for them.
Did I hear you right there? You're saying that burns larger than 20% TBSA could be detrimental to irrigate due to the risk of hypothermia?
Yes. So for that very reason, the 3-hour window becomes a really important criteria. It's really important to know that you have 3 hours. You don't need to dump that whole person into a lake or a big bath of cold water, because you will cause hypothermia. And potentially they have other priorities in care. You could have time critical priorities like airway, like breathing, like circulatory support, rather than thinking about, I need to cool the whole person right now, and you're trying to intubate and cannulate and put in catheters. That can't happen. So for a big burn, and that's for an adult, it's a burn over 20%. And for a child, that's a burn over 10%. You want to make sure that you do segmental cooling. So you prioritize certain areas first. And I would say things that matter to us as humans in the long term: faces, hands, genitals, and feet are really important to have a really good outcome. So if you could start cooling those areas, if they're burnt, that's where you start. You start cooling those areas for 20 minutes, remembering you have 3 hours. You don't need to do the whole person all at once. And then you can choose, okay, well, let's do upper limbs now for 20 minutes, and then we can do the torso for 20 minutes. And all the time you're cooling that bit, the rest of the person is packaged up and warming and kept as warm as possible protected from the ambient environment. Because one thing with big burns is, remember that they have lost skin. And skin is A, the largest organ in our body, and B, is a massive organ responsible for thermoregulation. And once that's gone, all you've got is a very wet, gooey patient who is losing heat in front of your eyes. So any burn patient that I would say that is below 37 degrees core temperature, they're hypothermic. For a burn, that's hypothermia. It's really, really cold for them. And you want to be trying to, A, reduce the heat loss and ideally increase that temperature in the patient. You want to keep them as warm as you possibly can. And cooling segmentally is one method of making sure you don't just dump loads of cold water on them and make them really, really cold. So protect the rest of the person whilst you're cooling them a bit at a time.
Can you comment on the use of cling film instead of fluffy gauze?
Yes, so gauze is bad news in applying directly to any wound. So that's not just burn specific, I would say. In any wound that's likely to be wet and gooey, if you're putting something like gauze, fluffed up or not, it will eventually adhere. And if you're in a really warm environment, that gauze will dry up much quicker as well and will adhere to the patient's wound surface. And when you go to remove it, it's an incredibly traumatic and painful process for the patient. So the initial guidance for care of those casualties that have just been injured, you've done your cooling and now you're ready to dress. Cling film works really well from the point of view that it protects the patient from the ambient environment. So you cover the wet, oozy wound. So you stop the heat from escaping and you stop any kind of penetration of bacteria and bugs and whatever debris is around from getting into the wound bed as well. So it's not a sterile intervention. It's a clean only approach, and it is purely a wound cover, not a definitive dressing. It allows you to visualize the wound. It allows you to continue assessing, sometimes capillary refill and whether the nerve endings are still alive. So if you want to assess for depth, that's a way to do it. And it allows you to transfer the patient without complicating it too much with massive bulky dressings. Now, our Australian colleagues are now raising concern that actually in that prolonged field care and delay to transfer, cling film ends up trapping the debris and the dirt and the infection underneath its surface. So actually, if you are not likely to get the casualty to definitive care within, say, 6 hours, ideally you'd have a different dressing strategy to apply to a burn wound. And for me, the dressing that you would, ideal dressing for a burn wound is something that's not going to be sticky. So we use a lot of silicone-based dressings or impregnating dressings, whether it's Vaseline impregnated dressing or other mediums that are maybe antibacterial that you apply on. So stuff that's not going to stick directly to the wound, that is permeable, so it has perforations that allows all of that leakage to still keep coming out. And you'll need a secondary dressing, which is your absorbent layer. Now, if you have gauze, you can use gauze, but gauze doesn't wick away from the burn wound. It will just absorb in the liquid and stay against the skin, meaning that actually your cold burn casualty is going to continue being cold and wet because that gauze is going to be just sitting there with all that wet exudate that's now cold and directly against their skin. So gauze is actually not a good secondary dressing in the long term, especially for bigger burns. So first layer's non-adherent, atraumatic to remove, something that won't stick, that allows permeability and exudate to travel through, and second dressing that will absorb all of the leakage. So some sort of absorbent pad or absorbent medium that will take it on. And then obviously you can bandage to secure if you need to for transfer as well.
Would you allocate improvising by using cling film, but poking a ton of holes into the cling film to allow some of that moisture to come out?
You could, but if you ever have a look at actual dressings that we use for wound care, the perforations are that many. It looks almost like your little fine sieve. There's so many holes. So you putting in a few holes into cling film won't necessarily achieve exactly what you're after. But I appreciate that actually in those environments, when you are limited to what you have, you use what you have. And if dry gauze is what you have, and there might be delay to patients being transferred, well, you use what you have. It's much better than not using anything at all and just leaving them open and getting cold. So that's not an option. Ultimately, we know from our colleagues who are in low resource countries that might treat patients with, banana leaf dressings. Who knew that such a thing exists? But it works really effectively. So if you're aware of other alternative ways that you can cover a burn wound, that works too. I would say with kind of that delayed field care, delayed transfer, the important thing might be for you to carry some sort of antimicrobial, antibacterial cream in your kit, because that's what they're going to need. The worry is always the burns will get infected. It's not a may not, they will get infected, and that patient could become very, very sick. And if they're getting burnt in an unclean environment and the initial care maybe wasn't perfect and obviously not contained because you're out in the elements, the infection is quite likely. So you need to carry some sort of antimicrobial, antibacterial in your kit to apply and then to cover with whatever dressing you cover it with.
There's pretty good research on honey, which is, there's no country in the world that you're not going to have access to it.
Yeah.
After the 20 minutes of cooling, would you advocate that as an option?
So in the Western world, I would say don't put anything on it. So certainly for those paramedics who are practicing in their standard care, we advocate that you cool, you cover with cling film, you transfer, and very soon they'll eventually get to the burns unit. If you apply any kind of cream, honey or any others, it means that when they get to the burns unit, we need to wipe it all off in order to assess the burn wound. It creates a barrier to our assessment, if you see what I mean. It creates another layer that we need to scrape off, which is painful, traumatic, potentially needs an anesthetic, and it's not necessary for that initial care. If you're talking about that delayed presentation, the delayed transfer and prolonged field care where you might be staying with the casualty for a number of days, then honey is a really good medium. We use it a lot in minor burns and big burns, in sloughy wounds that just are not suitable for surgery. Honey is a really good debriding agent, and it is a massive antimicrobial. Bees know well, that they really help us. So honey in the burn wound will kill off. It's really effective against Pseudomonas, really effective against many, many bugs and bacteria. So it is a good medium, but honey makes the wounds wetter. By its nature, it will seek out any non-viable tissue and start to liquefy it. So you have to be prepared for, if I'm using honey, this already very wet wound is going to become even wetter. And just as a point of note, having used honey in many wounds, you're going to need multiple sets of gloves, because those hands will get attached to your patients and everything else you touch is going to be sticky sweet. And basically you're just going to need to keep replacing your gloves if you're dealing with honey as a topical agent for burn wounds. But it's brilliant. I would totally advocate it in that prolonged field care scenario.
So that would address the Pseudomonas issue. I read something in PubMed just recently that cling film over burns has a high chance of getting Pseudomonas after 6 hours.
So it's not the cling film. It's the fact that the burn is a wet wound and Pseudomonas is a water-based bug. Pseudomonas love moist wound environments. So a lot of burn wounds will, within a couple of days, start showing signs of having Pseudomonas. And Pseudomonas is really bad news for skin grafts. It chomps away at the skin grafts completely. It makes them liquid, and you've put on a new skin graft and actually it's gone within a few days because Pseudomonas is in it. So Pseudomonas is not good. And yeah, you're right. So honey is very effective for Pseudomonas, but cling film over the top of the burn wound is not what's causing Pseudomonas. It's just that, especially if you've used water that's maybe an unclean source, and Pseudomonas is kind of, it's staph, so it's it's a bug that's on our tissues, that all of these bacteria that just migrate into the burn wound and cause initially colonization and eventually localized infection if they're really unlucky and it's a big burn that might cause systemic infection and sepsis in the long term. But there is no way to stave off that infection unless you're really keeping everything clean and completely aseptic.
In our courses in Malta and on our degree programs, we're advocating for twice a day, morning and night, to take the cling film off and irrigate and clean out the burn, and then cover again with cling film, and irrigate with liquid you're willing to put into your eye, not even liquid you're willing to drink. Is that evidence-based?
No. Like I already said, a lot of stuff in burn care, we're just kind of, I don't want to say making it up as we go along, but a lot of it is practice that we're just trying to make it as palatable and as easy to approach as possible. Now, I wouldn't say in the long term cling film is a dressing of choice. It's not a dressing. It is just a topical cover for a wound to protect it whilst you're transferring the patient. You want to have a more definitive dressing if you are treating them over 6 hours long. So cleaning the wound, yes. So you want to have potable water. On the burns units, like you mentioned, the ketamine showers, we shower patients with tap water all the time. So if you have, potable water that's available to you, you can wash the burn wounds with that. And quite often we'll put in some sort of soap agent as well to scrub off any debris, any bacteria that's accumulated on the surface. So that can be your hand soap, or we can use chlorhexidine if you have that available. That's brilliant for washing with just some water. And then you have to dress it. And cling film is not a dressing. So you need to think about what am I actually wanting to put on this wound in order for it to heal. For it to sit and stew inside a cling film is not the best practice. If that is all you have, that's a different story. So if you are literally remote, but I think that usually you would carry some sort of other salvage dressings for instances where you might suffer, sort of trauma that's causing bleeding, and you will have other bandage materials with you as part of your first aid kit. So I would say use whatever else rather than cling film in the long term.
So my final question for you is this: what advice do you have for the remote medic, the austere provider working in resource limited environments?
I have so much that I'd like to say, and I have to just check myself on the fact that I've not experienced that environment. So I don't want to be preachy about it. But I would say that think about the consequences of your very early decisions, of your very early actions. Everything you decide to do or not to do in that moment will have a direct consequence to near future and the long-term future for our patients. So you choosing not to call, you choosing to apply a different dressing to a different dressing, you choosing not to transfer and do prolonged field care, all of these decisions will lead to a consequence of some sort. And those consequences sometimes are lifelong, and they really complicate quality of life for our patients. Gone are the days when we are happy with just the fact that our patients have lived. Survival is no longer the bar that we have to cross, because most of our patients live. And our patients with 80, 90% burns survive and walk out of the burns unit. And you have to understand that I'm making decisions in the first moments and hours of that patient's lifelong journey. And what would I want that outcome to be if this person I treat were the person I loved and cared for the most? What's the outcome you would want for that person? And then you make your decisions in the field. Do your best. It is the worst case scenario. It's not ideal by far. But if you just give yourself an excuse in terms of cooling, well, it's too difficult to get water, or it's not ideal water source, you are potentially really complicating that patient's journey in the long term. Make every effort to get them access to as best practice as you can do. And I suppose that would be my advice, is that just consider the long-term long-term consequences of your decisions and your actions. Jane Goodall has a really good quote. She's not a clinician. She's a lovely lady who's really inspirational, but she said, what you do makes a difference, and you have to decide what kind of difference you want to make. And that would be what I'd like to say.
Krissie Stiles, we appreciate your knowledge and your input, and thank you for being our guest today.
Thank you so much for having me. I really enjoyed our chat.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.